Dr. Witteles, your hematology colleague comes to you needing some advice. A patient has cardiac AL amyloid, is going to undergo chemotherapy, and there are a variety of options. There are alkylating agents, there are immune modulating agents, there are proteasome inhibitors. How do you help guide the selection of therapy? Which ones actually aggravate the congestive heart failure?
Great, thanks. Well, so first I'd make the point that I briefly mentioned before, the importance of patients with AL, cardiac amyloidosis, being seen at a big referral center, if at all possible. I believe that for transthyretin amyloidosis, we really need to democratize the diagnosis and treatments, which is quite straightforward, and it's a common disease. AL amyloidosis, much less common, much more complex in terms of the treatments, and it's really important that these patients be seen by people who are experienced with treating the disease, and not just the cardiologist, but perhaps even more importantly, hematologist who has a lot of experience with AL amyloidosis. Myeloma, which is of course very related to AL amyloidosis, also arising from a malignant plasma cell, is something that is really bread and butter for hematologists. But the treatment targets are very different in myeloma than AL amyloidosis, particularly cardiac AL amyloidosis, where you really don't want to accept any residual pathologic light chain if at all possible. Whereas in myeloma, if you get pretty good control, often you'll back off the therapy and say that's pretty good. So really, really important for patients, if at all possible, to be seen at a big referral center. Now, in terms of agents of choice, I would say at this moment, the standard of care most of the time is for people to get started on a regimen called Cyborg-D, which the alkylator cyclophosphamide, the proteasome inhibitor bortezomib, and then the steroid dexamethasone. Although that, I suspect, may change in the coming months to a small number of years. Cyborg-D is overall associated with quite good response rates. It doesn't tend to be magical in everybody or many people at all, where they get started on it and within a cycle or two they normalize, but most people do have a response, and some people have excellent, and a smaller number, but still not insignificant, have what we call a complete hematologic response, where their light chains and their electrophoreses completely normalize. The key, though, is being ready, willing, and able to deftly move to other therapies if the treatment that was chosen is either inadequate, you're not having a good enough response, or intolerable from a side effect standpoint. And so if particularly for patients with significant cardiac involvement, if they're in a cycle or two and their light chains haven't come down very much, this is not somebody that you want to give another 6 months and see what happens. It's time to make a change. And the beauty with AL amyloidosis is that we now have so many different options. We have multiple classes of chemo and immunotherapy, and we have multiple agents within each class. So somebody might not respond to, for example, to lenalidomide, but might respond to pomalidomide. They might not respond to bortezomib, but they might respond to carfilzomib. And then an agent that has, I would say, really revolutionized the treatment for many, which is the monoclonal antibody daratumumab, which is actually currently being studied in a clinical trial called Andromeda, where people with cardiac amyloidosis are randomized upfront to therapy with either the Cyborg-D chemotherapy I was just mentioning, or a combination of Cyborg-D plus daratumumab. The results haven't come out yet. I will be utterly shocked if daratumumab does not add significant extra control for light chains, because we've so obviously seen it in patients who have gotten to daratumumab after failing other treatments. Now, to the question of the cardiac side effects of these agents. So fortunately, most of them are actually well tolerated from a specific cardiovascular standpoint. Steroids, of course, can cause salt and water retention, as I'm sure all cardiologists are familiar with dealing with and sometimes need to be dealt with. The agent that has the most evidence for causing true cardiac toxicity is carfilzomib, one of the proteasome inhibitors. What I would say is that the toxicity of carfilzomib does not tend to be systolic heart failure. The clearest toxicities are hypertension, increased rates of thrombosis, and diastolic heart failure, or the last being the most challenging because obviously these patients, that's what they tend to have, is diastolic heart failure. I certainly would not go so far as to say you cannot use carfilzomib in patients with cardiac amyloidosis, and we've certainly found it to be helpful in patients who have failed bortezomib and have had good responses on carfilzomib. But you got to be very careful with it and know that cardiotoxicity can be a real issue with that drug. In terms of the so-called IMiDs, things like lenalidomide, pomalidomide, thrombosis is the biggest risk. So it's important to know that, and in some cases to prophylax. So when you read about hematologic therapy for patients with AL amyloidosis, a lot of the algorithms will point to upfront saying, is the patient a stem cell transplant candidate, and really having that be a divergent point. I could not disagree with this strategy more. Stem cell transplant, we're talking about an auto stem cell transplant, not an allo transplant. So we're not getting any graft versus tumor effect. All an auto stem cell transplant is in this disease is a way to give a higher dose than you could otherwise give of a single class of chemotherapy, namely an alkylator agent, and then you rescue by giving them their own marrow back. This arose because the initial treatments of AL amyloidosis, the options for therapy were very limited, namely melphalan and prednisone, later melphalan, dexamethasone. And so the idea was, well, if we give higher doses, patients should do better. And there was a number of retrospective studies that looked and said, yes, patients who got stem cell transplants did seem to do better than the patients who didn't. But of course, they were hopelessly confounded because there's a reason why those patients had gone on and gotten stem cell transplants and the others hadn't. There's only a single randomized trial that ever compared the two. And importantly, that trial was done in an era when standard chemotherapy was nothing like it is today. It was melphalan and dexamethasone. And yet in that clinical trial, there were actually better outcomes, including better survival in the patients who got the standard chemotherapy than the auto stem cell transplants. When you think about in today's world where we have so many better options, I would say stem cell transplant in my mind should be a potential option for patients, particularly if they fail others, but should not be what the goal is that you're trying to get to.
We've got a lot to talk about in terms of TTR therapies, and there have been some really monumental publications that have occurred.